Good morning or afternoon, everybody. Welcome to a packed health subcommittee. Thank you guys for attending. Mr. Clerk, do you mind opening the roll for us? Everybody, please sign in. And take that. Mr. Clerk, please take the roll.
Mr. Chairman, you have 7 members present. You have a quorum.
Thank you, Mr. Clerk. It has been a little chaotic today, so we apologize for starting a few minutes late. First, do any members have any special announcements or requests out? I do have a few. I'll recognize American Academy of Pediatrics. They're here today, so welcome you guys for being here. And then I see two of my own friends, Dr. Scott Spivey. I see him. He is actually my optometrist back home. And then a special guest, Dr. Tanya Reynoldson, is here from Camden. Dr. Reynoldson has been fighting cancer, and guys, she has been clear on her last scan. So thank the good Lord for that. So thank you for being here, and we'll get rolling. So a couple of house items. House Bill 2053 is off notice. Item number 3, House Bill 0688 is off notice. Item number 9, House Bill 1979, roll 1 week. House Bill 1807, 1 week. House Bill 2166, 1 week. Item number 26, House Bill 2110, 1 week. And number 29, House Bill 1957, 1 week. With that committee, that moves us back to our regular calendar, and we will jump around a little bit today as we have several bills with testimony. But I will start with item number 2, which is House Bill 2598 from our Leader Camper. You got a motion and a second, ma'am. You're properly recognized.
Thank you, Mr. Chairman and committee. I have another bill across the way. That's why I was hoping you would go ahead and take me up. Thank you. So, Mr. Chairman, committee, what this bill does is direct the health department to the Commissioner of Health to conduct and study examining the levels of independent practice granted to certified nurse midwives. And so what we're trying to do with this bill is direct the commissioner to look at existing resources to study what our neighboring states are doing with certified midwives practices, examine variations of supervisory, collaborative, and independent practice models, and then report back to us so that we can make better informed decisions about midwifery. So that's what this bill does.
Thank you, Leader Camper. Any questions for the leader? As somebody whose wife is 35 weeks pregnant and seeing a midwife, I greatly appreciate what they are doing and the work they do. So I'm excited for this bill to move forward, hopefully. No further questions. We'll call a question on the bill. All those in favor of House Bill 2598, press aye. All those opposed, no. All members voted. Any members wish to change their vote? Mr. Clerk, please take the vote.
Mr. Chairman, you have 6 ayes and 0 nays.
The ayes have it. House Bill 2598 moves on to Healthful. Oh, we got you again. House Bill number 2049 by Leader Camper. Got a motion and a second. You are properly recognized.
Thank you, Mr. Chairman and committee. What this bill deals with is uterine fibroids. It establishes a commission within the Tennessee state law to examine, advise, and make policy recommendations to us regarding uterine fibroids. Now, the bill will establish a state uterine fibroid commission. It will be 11 members. Healthcare professionals will be on there. Representatives from hospital and nursing organizations will be there. 2 from people that have been diagnosed with it, and 2 from the General Assembly, 1 in the House, 1 in the Senate. They will provide information back to us, a report to us based on the studies that will be done within the resources of the Health Commission. And they will hold public hearings, and I'd appreciate a favorable vote.
Thank you, Madam Leader. We do have a testimony for this one. Without objection, we'll go out of session and recognize from the Department of Health, Mr. Mike Critchfield, if you're in. Thank you, sir. If you don't mind stating your name for the record and then who you're with,
Mike Critchfield, Department of Health.
and you'll have 3 minutes. Thank you, sir.
Thank you, Mr. Chairman. I hope I don't need all 3 minutes. Our issues with this bill are, it's just creating, while the intent of the bill is very important and we want to make sure we're taking care of people with uterine fibroids, we have problems with creating another commission. We think it could be better served as a report by the department and make sure we're using funds more responsibly.
Any questions for Representative McKenzie? You're recognized.
Thank you, Mr. Chair. So are you saying that the issue can be understood within a year in a report, and that's all that we kind of need to do to understand the issue of fibroids? Because I know it's pretty prevalent, in my circle of folks that I know. So I guess I'm understanding. I'm trying to understand from a validity standpoint. Are you saying that the department just doesn't want to do it because it's cumbersome, or the issue is not that important that would drive the department to want to do it?
No, we think the issue's very important. I don't want to undermine that. We just think that we can utilize existing resources in our Family Health and Wellness Division rather than funding an entirely new commission.
So it's a quick follow.
Representative.
Thank you. So what type of information have we done to this? Since you said it's pretty much existing, what type of reports have we done to understand what the fibroid condition is and women across the state?
I can get back to you and I'll send you our existing resources on that.
Thank you.
Any further questions? Not seeing any. Thank you, sir. We'll
Thank
go back in session.
Thank you, Mr. Chairman.
Madam
Mr. Chairman, this is absolutely the first time that I've heard that the department had an issue with this bill. So I don't mind working with them, but I feel if they had an issue or concern, one, they would have come to the member and had a whole conversation. Secondly, this is a very important issue. And if it had risen to a level of priority within the department, it wouldn't be a need for this. But there is a need because it hasn't. Now, I'd be very willing, if your committee is going to still be meeting, to roll this a week, to have an opportunity to work with the department, because I don't like being blindsided. Number one, they know my number, they know where I'm at. That's a problem. This is an important issue. You can ride down the highways and you see the signs telling people about it. They know it's an issue, but it may not be a priority. So if it's not a priority for the department, which they have a lot of good stuff going on, I get it. They need to be working with the member to try to come up with a solution before we get in this committee and make those type of testimonies. So if it's okay with the committee, can I roll this a week, or if it needs to be a motion, I'm willing to work with them.
Chairman Terry, you're recognized. No.
Thank you. I was just gonna say, we could roll it to the end of the calendar, because I don't know that we're gonna get to the end of the calendar and serve the same purpose and save you a roll.
Hey.
Oh, we're good. Roll to the end.
I'm with it.
That'll work. Yes, ma'am. We'll roll you to the end of this calendar.
Thank you, Mr. Chairman and committee. Thank you, Representative.
I believe we have a short technical difficulty real fast we're going to address. He's got a log back in. We'll take just a brief recess. Thank you for holding with us. That brief recess, we will all need to log back in on your keypads if you do not mind. The system had to be reset. All right. And this brings us up to item number 5, House Bill 1909 by Chairman Hicks. Motion and second. Sir, I believe you have an amendment as well.
Yes, sir. That is correct. 014241.
That is correct. We got a motion and a second. All those in favor say aye. Aye. Opposed? No. Ayes have it. You are properly before us, sir.
All right, Mr. Chairman, thank you. Members, this bill was brought to me by the Tennessee Association of Marriage and Family Therapy. This association represents the interests of licensed marriage and family therapists across the state of Tennessee. The bill makes some technical corrections and rewrites the bill. So the bill will have a meaningful impact on the industry. Right now in Tennessee, the demand for mental health support and services is extremely high. Virtually all of Tennessee is rated as a mental health provider shortage area. Tennessee lags behind most other states regarding mental health providers per capita, ranking 44th in a recent study. Nationwide, there is one mental health provider for every 350, but in Tennessee, there is only one provider for every 590 residents. House Bill 1909 proposes several changes regarding the marriage and family therapist in Tennessee to help address these issues. This bill will address portability challenges. Also, it encourages new graduates to work in community mental health and similar high needs, modernize terminology, also adds clarification to the licensed marriage and family therapist definition, revises board-approved supervisor requirements, and of course, the effective date for this will be July 1st, 2026. Thank you.
Thank you, Mr. Chairman. Any questions for the sponsor? Not seeing any. Mr. Clerk, if you don't mind opening the vote. All those in favor of House Bill 1909, vote aye. Those no, vote no. All members voted. Any members wish to change their vote? Mr. Clerk, please take the vote.
Mr. Chairman, you have 8 ayes and 0 nays.
The ayes have it. House Bill 1909 moves on to health full.
Thank you, Mr. Chairman. Members.
This brings us to item number 6, House Bill 1828 by Chairman Hicks. Motion and second. You are properly recognized.
Chairman, thank you very much. Members, this is, I think, is a really good bill, but it's just not ready for prime time just yet. So I'd like to take this bill off notice.
Without objection, that bill is taken off notice.
Thank you, Mr. Chairman.
Thank you, sir. This brings us up to item number 7, House Bill 2029 by Chairman Faison. Motion and second. You have an amendment, I believe, with this bill, sir.
We do, yes, sir. It's a technical amendment, drafting code 013349.
Yeah, motion second. That is properly recognized. All those in favor say aye. Aye. Opposed? The ayes have it. You are properly recognized, sir.
Thank you, Mr. Chair, committee. Hope you're well. This bill is for dietitians and their practice, and I can go through all the details of it. We also have somebody who signed up to speak on it. What would you like to do, Mr. Chair?
Yeah, if requested. If requested, so would the committee like to hear from them? Yeah.
Right on. Thank you, Chairman Williams. The bill modernizes Tennessee's dietetic law, which was last updated in 1987, by providing pathways to licensure for all qualified dietetic and nutrition professionals consistent with their education, training, and demonstrated competency, while appropriately focusing regulational services that pose a risk of harm if provided and unqualified individuals, namely medical nutrition therapy. The bill seeks to do basically 3 things: protect patients, then supporting access, timely cost of effective nutrition care, and then the bill preserves consumer choice.
Thank you, Chairman, for that. Do we have a question from Chairman Williams? You're recognized.
Yes, Chairman Faison. Just a quick question. Does your wife give you permission to carry this bill?
Chairman, you're recognized.
Thank you, Mr. Chair. Chairman Williams, she encouraged me to carry this bill. Yes, sir.
For the members might not know, his wife is a dietitian, so she's still working on him in his diet. But other than that, he's doing great. But super big fan of your bill. Thanks for bringing it. Send Miriam our best.
That might be. It is a health committee, so it's not really out of order. Any follow-up? Any other questions for the member? Without that question on the bill, Mr. Clerk, please open the vote. All those in favor of House Bill 2029, press aye. Opposed, no. If all members voted, any member wish to change their vote? Not seeing any. Mr. Clerk, take the vote.
Mr. Chairman, you have 8 ayes and 0 nays.
The ayes have it. House Bill 2029 moves on to health full. That brings us up to item number 8, House Bill 2100 by Chairman Faison.
Thank you, Mr.
Hold
Chair.
on, we got a motion and second. Motion second. Now you're properly recognized.
Very good to be with y'all. This bill, I didn't think that we would have to carry because the governor's CON bill had this language part of it. And there was a different bill that moved forward yesterday with the CON. So I'm hoping to complement it, make sure we get this passed. With your indulgence, I'll just tell you a brief story. I have been following and studying and working for over a decade now, drug addiction. And I have maintained for years that in America, we don't get it right when it comes to helping people who are truly addicted to an illicit substance. America as a whole has around a 15% addiction rate. And Tennessee has over an 18% addiction rate, which we're higher than the national average. In my studies, I noticed that Portugal, comparative in size, is a little bit bigger than us, around 10, 11 million people in Portugal. Their addiction rate is some of the lowest, and it's around 6%. And so I went with some addiction specialists last year to Portugal, and I spent several days with their government. They have a lot of policies that won't fly in Tennessee, and I understand that. But there's one thing that I thought was so impressive that they did is they made methadone readily available. And there were several times during that week that at lunchtime, I would go and see a mobile methadone clinic. And I watched and talked to white collar professionals who would literally come in and get a little shot of methadone and go back to work. I saw every socioeconomic status that you can imagine. And I know some of you are sitting there saying, well, Jeremy, methadone is a drug. So you're trading one drug for another. The reason that impressed me, though, is they haven't had an overdose in 3 years in Portugal. While I've been sitting in this room, we've probably had 3 overdoses in Tennessee. Overdoses happens because the drug addicts are getting stuff off the streets. I hope that they can get to a place in their life that they are not an addict. But what I do know is if they can get something that's regulated and safe, that will help them on a journey out of addiction to an illicit substance, that's a good thing. As y'all know, if you've been in this space at all, you know that methadone is already legal. It's being used in Tennessee, but there's a CON on it. And we've had an unbelievable amount of talks about CONs in the last few weeks, including yesterday. It's coming out of the Senate and out of the House. There's a CON on methadone clinics. This bill just simply takes that away. You still have to follow all your local ordinances. You still have to get licensed from the state. You can't have it unless you get a prescription for it. There's still all the other safety nets other than have to go through a CON to be able to do this. And that's what the bill does.
Thank you very much, Chairman, for bringing this to us. Any questions for the Chairman Terry? You're recognized.
Yeah, thank you, and appreciate you for bringing the bill and having the discussion. Just if you can just briefly walk me through on an exemption applying to counties without an actively licensed acute care hospital. Are these going to be tied to hospitals, or you said go through all the licensing and they're tied? These aren't just going to be popping up somewhere. They're tied to something.
Chairman, you're recognized.
Thank you, Mr. Chair. Great question. I included in the bill that a nonprofit that has a board certified physician that would be a part of the treatment would have to be on board. So you wouldn't just have to be a hospital, acute care hospital or a drug clinic. We actually have one in Knoxville and it's working incredibly. It's a nonprofit substance abuse counseling center. And we have Tennesseans that go there every day, but they went through the CON to do it. And so it would be set up like that, whether you can do it anywhere that, as long as you have a board certified physician to be a part of it.
Any further questions? Not seeing any. Question on the bill? No question. Mr. Clerk, if you don't mind opening the vote. All those in favor of House Bill 2100, vote aye. Opposed, no. Have all members voted? Any members wish to change their vote? Not seeing any. Mr. Clerk, please take the vote.
Mr. Chairman, you have 5 ayes, 2 nays, and 1 present not voting.
The ayes have it. House Bill 2100 moves on to health full.
Thank you.
This brings us up to item number 10. I believe he is here. He is. House Bill 2358 by Chairman Hawk. Motion and second. You are properly recognized, and you do have an amendment, sir. Oh.
Thank you, Chairman and members, for giving my voice today. It's good to be in front of this committee. I do have an amendment, drafting code 013776.
Motion and second on the amendment. All those in favor of adding amendment 103776, say aye. Aye. Opposed? No. Ayes have it. You're properly recognized.
Thank you.
And welcome back to your former committee.
Well, thank you,
Glad to have
Chairman. And I do miss this committee greatly. I really do. We did some great work on this committee. Many members are still here. Thank you very much. This bill deals with something we started while I was chairing Health Committee, working with Chairman Terry in the TANF arena, temporary assistance for needy families. And specifically, it is dealing with some of our need to fully fund Child Care Development Fund. And what it does is requires the Department of Human Services to annually transfer from the current fiscal year's TANF block grant to the Child Care and Development Fund, an amount sufficient to fund participation in the Smart Steps program. Child care is a workforce development issue that we're having all across the state of Tennessee. These are families that want to be in the workforce and want to stay in the workforce and better themselves. And through this mechanism, it's going to put funds where they can be best utilized to keep our working parents in the workforce. With that explanation as amended, I stand for any questions or comments, Chairman and members.
Thank you, Chairman. Any questions for the sponsor? Chairman Terry, you're recognized.
Thank you. Thank you, and appreciate you bringing the piece of legislation, and appreciate all the work that you've done in this arena. I just, for the members, and hopefully you have this information, and my apologies for not seeing you beforehand, but my understanding is we used to have a surplus in the CCDF, and that's been spent down. Can you discuss, or do you know how that process has worked to where we don't have the funds there such that we have to make this transfer?
Chairman, you're recognized.
Limited knowledge of the transfer, of the reason. There have been some changes in federal funding where there was a significant reduction of nearly $45 million in the child care fund. Is that what we're talking about?
Chairman, we do have somebody we can go out of session
Okay.
if you want to speak to that on that behalf. If you guys don't mind, without objection, we'll go out of session. We have the expert in the room, so we'll ask her all those hard questions. So, yeah. That's right. Please state your name for the record and who you're with, friend.
Thank you. I'm Callan Baggett. I'm the Assistant Commissioner for the Department of Human Services. And so to your question, if I think I'm understanding, you're asking about the previous surplus that was with CCDF. That has since been utilized for a number of different projects across our child care space, including covering existing Smart Steps folks. And we've basically spent down our reserves in the CCDF fund.
You're recognized.
All right, and so I guess and we can go back into session at some point to ask this to the chairman, but I guess obviously with TANF, we have the list of things that we can use it for, and this would fill in with that. But could you explain with what we have obligated right now from our surplus that the chairman had worked diligently on this committee as well? The obligations we have to that, how much we're currently getting, how much is being utilized, and then how much of this can we move over?
Yes, I'm happy to take that question. And so, if this bill, we are deferred on the amendment, but if this were to pass, this would be a policy change for the department, and we would have to renegotiate or eliminate some of the existing TANF contracts and projects moving forward. For example, things that might be considered as our partnership with the Department of Health and they may not be in the room, but their nurse family partnership work that we do with them, they receive around $30 million in TANF funding. So that would be a project that could need to be renegotiated. Also, some of the work that this committee has done with our TANF Opportunity Act partnerships, the 7 pilots that are doing great work. We do have a proposed bridge program for $1 million grants in the next year that would sustain them while we create a new competitive grant process for a new TANF grant that would be coming out based off of the research that's been done with those 7 pilots that Chairman Hawk was very passionate about carrying that legislation and being a fierce advocate for. So it would require us to do a little bit of removing, renegotiating, eliminating potential projects. But if that's a policy decision of the legislature, then we will carry that out.
Recognized.
And can you mention for the members here, just remind everybody in the audience, how much are we getting yearly?
Yes.
And how much is that already obligated?
Yes. So each year, it's the 30th year of the personal responsibility plan that created TANF. It's 30th anniversary. We receive $191 million each year. On average, we budget for about $60 million-ish in direct assistance. And don't quote me exactly on that, but that goes to the direct TANF recipients. We have our administrative cap that we use to fund staff and salaries and technology, things like that. And then the remaining dollars we use for a variety of purposes for mission critical contracts, such as our partnership with Big Brothers Big Sisters, communities and schools. And that nurse family partnership project, which it's not called that at Department of Health, but it covers that. Those would be projects that are funded out of the remaining TANF dollars. Whatever is unspent in that year's allocation then is rolled into the reserve and goes out into your communities for the community grant dollars. So then that would also affect our ability for community grants moving forward.
Okay. And so that was my question. So we have 120 million each year.
Ish.
And so when you talk about a policy decision, what we're doing here is prioritizing the CCDF for part of that. Okay. All right. Thank you.
Any more questions for the department? Thank you, ma'am. Without objection, we'll go back in session, and Chairman, you're recognized.
Chairman, if I could restate, and we have someone here that we've been working the initial push for the TANF pilot programs that we have seen being successful now largely came about with some work that we have had with the Tennesseans for Quality Early Education. TQEE has worked diligently in this space along with the Department of Human Services. I should have stated this in my initial comments, and hopefully this will help bring some clarity to the intent of House Bill 2358 will to use the unobligated federal TANF funds to clear the child care wait list to ensure eligible working families can participate in the Smart Step program. So that is the intent of the unobligated portion that you just heard Deputy Commissioner describe there.
Any further questions for the sponsor? Not seeing any question on the bill. Mr. Clerk, we don't mind opening the vote. All those in favor of House Bill 2358, press yes. All those opposed, no. Mr. Clerk, take the vote.
Mr. Chairman, you have 8 ayes and 0 nays.
Ayes have it. House Bill 2358 moves on to health full.
Thank you, Chairman and members. Somebody once said you can never go home again, but it's good to be home with
That's
you
right.
guys. Thank you all.
Good to have you, sir. Thank you. This moves us up to item number 11, House Bill 2351 by Chair Lady Littleton.
Second.
Motion and second. No amendments, so you are properly recognized.
Thank you, Mr. Chairman. I don't get to visit this committee very often, so I'm glad to be here. This bill sets up a path for nursing students to become CMAs based upon passing specific nursing classes with an appropriate grade. Allows 90 days to complete the program. It is currently 30. Authorizes the Board of Nursing to adopt a program for out-of-state programs and makes minor adjustments to help keep programs available.
With that explanation, any questions for the sponsor? Question on the bill has been called. All those in favor of House Bill 2351, vote aye. All those opposed, no. All members voted. Any member wish to change their vote? Not seeing any. Mr. Clerk, take the vote.
Mr. Chairman, you have 8 ayes and 0 nays.
The ayes have it. House Bill 2351 moves on to health full.
Thank you, Mr. Chairman and committee.
This will bring us up to item number 12, House Bill 1835 by Mr. Chairman Hale. Got a motion?
Second.
Motion and a second. You are properly recognized, sir.
Thank you, Chairman and committee. House Bill 1835 would require the Department of Human Services to apply for and, if approved, participate in the summer EBT program. It's a federal program that provides families of children on free and reduced lunch with $120 for meals over the summer. This program would feed nearly 700,000 children across all 95 counties in Tennessee. This bill is aimed at feeding our children and providing for their needs. With that, I stand for question.
Thank you, Mr. Chair. Any questions for the sponsor? Representative Mitchell, you're recognized.
Yeah, thank you, Mr. Chair. I just want to applaud you, Representative, for doing this. It's a shame you have to do this, but thank you so much for doing this.
Thank you, Representative. I appreciate it.
Any further questions or comments? Not seeing any. Mr. Clerk, open the vote for House Bill 1835. All those in favor say aye. Opposed, no. Mr. Clerk, take the vote.
Mr. Chairman, you have 7 ayes and 0 nays.
The ayes have it. House Bill 1835 moves on to health full.
Thank you, committee and chair.
This will bring us up to item number 13, who's been waiting patiently. House Bill 1806, your motion and second, you are properly recognized, sir. And you do have an amendment, I believe.
Thank you, Mr. Chairman, and thank you, members. I believe we have an amendment that makes this bill. Amendment 011566.
That's not what I have in
That's
front
not
of
what-
me. What about 014601?
Oh, okay. Yes, I'm
You
sorry.
got that one?
Got that. Yes.
Hey, that'll work. We'll
That'll
take
work.
that one.
Got my hand full of papers.
Hey, that's all right.
Thank you so much. Mr.
We got
Chairman,
a
and
motion second on that. Motion and second. All those in favor say aye. Aye. Opposed? The ayes have it. You are now properly recognized.
thank you, sir. And what this bill does, it is encouraging the Department of Human Services to apply for and to distribute as well as apply for the summer EBT program and to distribute it to the children. That's what the amendment says. I would stand ready if any questions you might have.
Thank you, Ms. Representative. Any questions from the committee? Chairman Terry, you're recognized.
Thank you for presenting this bill, and we just passed a bill similar to this. Can you kind of explain the differences of what you're looking at doing?
Well, I was not privy to the bill that you just passed. I'm not for sure how much in line it is. I'm carrying this one for Senator Yarborough in the Senate. And so I just learned about the bill just before me this morning. I don't know if they are the same or if they different.
Chairman, you recognize?
Could we have legal kind of just?
Let's do that. Let's go out of
explain
session
it?
real fast and ask legal. Without objection, we're out of session. And state your name for the record, please.
Of course. Heather Asbell, Legal Services. These bills are extremely similar to one another. Your bill specifically talks about for the purpose of providing nutrition assistance through the EBT during the summer months for eligible children to ensure continued access to food when school is not in session. The bill that was just passed, House Bill 1835, essentially does the same thing. It just doesn't go into as specifics. It does require the department to apply for and if approved, accept federal grants and other federal funds available to the state through the summer EBT program, which is essentially what your bill is doing as well.
Representative, you
Question
recognize.
for legal, does it also encourage them to distribute them to the kids through the EBT program?
House Bill 1835 specifies, it says in any year in which the summer electronic benefits transfer for children established under the federal code is offered, the department shall apply for and if approved, accept federal grants and other federal funds available to the state through the program for the purpose of providing nutrition assistance during the summer months for each eligible child to ensure continued access to food when school is not in session, which is what your bill says. But yours, I will say yours does specify the department shall submit the application to the program no later than January 1, 2027. And Representative Hale's bill did not specify that. It just says in any year in which the EBT program is offered.
Representative.
Thank you, Mr. Chairman. I think that would be at your and the committee's discretion is which one, because we definitely want this for the children and as quick as possible.
Chairman Terry. Oh, back in session. Representative Mitchell, you got something for out of session? No. Okay. Without objection, we'll go back in session. And now, Chairman Terry, you're recognized.
Thank you. And it's obviously based on the vote on the last bill, the will of the committee is supportive of the concept of this. I mean, I would be supportive of moving this forward, but having you and the other legislator get together and kind of get the ideas for one plan, because obviously we're supportive of the idea. And if something goes awry with one bill, we have a backup. So I would be supportive of that.
Representative Mitchell, you're recognized.
Yeah. Thank you, Mr. Chairman. I appreciate Representative Terry. I think this would send a clear message to the administration that both sides of the aisle intend on this happening. And I say, as Representative Terry said, let's send them both through and let them figure out which one's the best. And if one needs to amend the other to improve, let's do that. But I think it's sending a clear message that both sides of the aisle are determined to feed children in the summertime in this state, and we're not going to let children go hungry.
Thank you, Representative Mitchell. I serve at the will of this body. So with that, any further questions or concerns? Not seeing any. Mr. Clerk, please open the vote. All those in favor of sending on House Bill 1806, aye, and opposed, no. Mr. Clerk, take the vote.
Mr. Chairman, you have 7 ayes and 0 nays.
The ayes have it. House Bill 1806 moves on to health full. Thank you, sir.
Thank you, Mr. Chairman. Thank you, committee.
We're going to briefly go out of session or out of order just a little bit. We got some members that have brought folks from a long way and then some that need to move around real fast. So I'm going to move on to item number 23, House Bill 2195. Representative Gant. In a motion and a second, and you have an amendment, I believe.
Yes, sir. Let's see. Drafting code. No, I do not have an amendment.
No amendment.
Yes, I do have an
You do.
amendment.
Yes, sir.
I am sorry. I'm 013955.
That is correct. Get a motion and second. All those in favor say aye. Aye. The ayes have it. You are properly recognized.
Thank you, Mr. Chairman. I'll be brief. I know we've got a big vote coming up, and I will not belabor the time here. So This legislation requires an air medical communication specialist to be certified within 6 months of employment from either one, a flight program that is accredited by the Commission on Accreditations of Medical Transport Systems, or two, a flight program through the International Association of Medical Transport Communication Specialists. Requires each employer to ensure that an air medical communication specialist employed by the employer obtains the proper certification. Requires an employer to maintain documentation verifying the current certification of employer's air medical communication specialists and to make the documentation available to the Department of Health for inspection upon request, Mr. Chairman. I yield back.
You've heard the bill. Any questions for the sponsor? Not seeing any. Mr. Clerk, please open the vote. All those in favor of House Bill 2195, press aye. Opposed, no. If all members voted, any members wish to change their vote? Not seeing any. Please take the vote.
Mr. Chairman, you have 7 ayes and 0 nays.
The ayes have it. House Bill 2195 moves on to Health Full. This brings, yep, you're good. And we'll move just a little bit more around. This brings me up to House Bill 2088 by Chairman Powers. There's no amendment. Get a motion and a second. Motion second. You are properly recognized, sir.
Thank you, Mr. Chairman and committee. House Bill 2088. 2 years ago, we passed a bill requiring independent home care nurses to become home care organizations regulated by the Health Care Facilities Commission. They were required to set up an office, hire staff, and have records available for any possible audit or compliance check. They were also required to obtain another license. However, we found, especially in the rural areas, that some of the nurses only have a small number of patients, and trying to establish an office, hire staff, et cetera, would be very difficult and expensive with only a small number of patients. I'll give you an example. I had one nurse that she has 2 patients and one of them died. So now she has 1 patient. So House Bill 2088 would allow those independent nurses to be exempt if they have 4 or few patients. It would also allow them to securely store the records and requires the Department of Health to provide a space for them to do that. And with that, Mr. Chairman, we have an independent nurse here to testify on behalf of this bill. If we could go out of session, Regina Barrett is here with us today.
Absolutely. Without objection, we have a couple of folks to speak on this bill. So we have Miss Regina Barnett as well as Mila LaFew. If you don't mind coming up, and you guys can both sit on here, and then
Yeah, Barnett, it's okay.
oh, we were out of session. There we go. Okay, if you guys don't mind, whichever would like to go first, speak your name into the record, and then you'll have 3 minutes to speak. We can start here with you on the left, ma'am, if you'd like. State your name for the record and 3 minutes, please.
My name is Mila LaFew. First, I want to say thank you, Mr. Chairman Martin, and the committee for hearing me today. Again, my name is Mila LaFew. I'm a registered nurse from Fentress County. I'm here today representing Quality Private Duty Care and the Tennessee Association for Home Care. As a nurse, I'm very passionate about advocating for patient safety. Mr. Chairman and committee, this bill creates a significant regulatory imbalance. Licensed private duty and home care agencies in Tennessee operate under strict regulatory standards. They maintain offices, employ admin staff, carry employee insurance, maintain policies and procedures. We undergo inspections, provide supervisory oversight for patient care. These requirements carry real cost, but they also create safeguards for patients and families. Allowing some providers to bypass these standards, these structural requirements and standards while operating in the same marketplace creates an uneven playing field. Agencies that comply with the law will continue to bear the cost of regulatory compliance, while others may operate with far fewer obligations. This bill requires the Department of Health to provide and secure storage space upon request. That means taxpayer-funded space, security, administration, and oversight for private businesses. At the time when resources are limited, we should not shift private operating costs onto the state. This bill also raises practical enforcement questions. When a complaint is filed or a concern arises about patient care, investigators need access to records, policy, operational oversight. If a provider has no office and no administrative structure, it becomes significantly more difficult for regulators to investigate issues efficiently. If these standards are necessary for 5 patients, then they are necessary for 4, 3, 2, and even 1. These having 2 sets of rules, it undermines regulatory and fair competition. And we're not stating here today that that they can't operate and serve fewer, or that they can't serve the 4 patients or more or less, but they either need to meet the same requirements as the rest of the industry does, or serve those patients through a home care organization. I also like to take this time to thank Representative Powers. He did take the time to meet with the association back in the fall, and we do appreciate you working with us.
Thank you, ma'am. That's the 3 minutes. I greatly appreciate you. Now, Ms. Barnett, you are recognized.
I'm overwhelmed with the work we do here, so I just wanted to thank you all.
I just turned it on. I'm sorry.
State your name for the record, please.
So, my name is Regina Barnett. I'm a registered nurse with 37 years of experience, including home health, hospice, and teaching nursing and fundamentals at a community college in Tennessee. For the past 8 years, I've provided care for former U.S. Department of Energy workers and under the DEE OIC program as an independent nurse. I'm here with 15 other nurses, professionals, patients in support of this bill who have independent nurses as their provider. At the heart of this bill, which I agree with her, is safe deliverance of care for our patients, and really also patient choice. Independent nurses have very few patients, like Representative Powers said. We do not intend to open offices, hire or build companies. Most of our patients and their families sought us out directly for their care. We do not intend to take business away from home care agencies. In fact, I feel like we fill in the gap where you're in a rural area and it's underserved. We can go in where they maybe don't have the staff or maybe the travel restraints. So I understand that what she was saying is we're not regulated. So that's what I was going to talk about. Nursing practice in Tennessee is regulated, and by you, and I'm so appreciative of it. The bill does not eliminate oversight. We are overseen by the Tennessee Board of Nursing, and that consists of a 41-page list that you all are quite aware of our regulations. We're also regulated by the Department of Labor, and that is a 665-page policy procedure book that we are regulated by. It's a federal program. Our patients are their priority. They have claims examiners, and that program also has physicians and nurses that oversee our care, and they do allow independent nurses to provide in that program. The other ones, oversight follows the nurse really in a situation like us because we're out seeing our patients and not really the setting. Home care is deeply personal. It happens at the most private space in their home. Patients deserve to know exactly who's walking through the door. They deserve community, independent nurses. They show up. We're consistent. We develop a rapport, and that consistency really matters. Because we know our patients, we recognize subtle changes. And last week, I was assessing my patient and noted changes in his breath sounds and decreased oxygen saturation. I called his treating physician. She ordered mobile labs and chest x-ray, then called antibiotics to a small town pharmacy, and they promptly delivered antibiotics to his home. Early interventions in this patient was very important to prevent complications.
That's
We
3
do
minutes.
have
Thank you.
oversight, huh?
That's 3 minutes. Thank you, though.
Sorry.
Any questions for the speakers? Representative McKenzie, you're recognized.
Thank you, Mr. Chair. And thank you all for coming here today. To the independent nursing person, I guess you talked about the things you all caught early in the process. I don't think you're saying that you did those things because you were a single operator. You're just a good nurse, I guess.
And the physician oversights everything. And we have a close relationship with her. And some of the representatives should have gotten a letter in support of working with us. There were 3 physicians that we work with, and they wrote supportive letters for this legislation. So my point being, I work very closely and under their plan of care. I do not do anything that the physician does not order.
Representative, you're recognized.
Thank you. I guess my point is, I'm sure the other folks do as well. A direct question, in terms of liability insurance, is there any requirement for y'all to have that?
Yes.
I was just having her address.
Okay.
Oh.
It's a procedural thing, I'm sorry.
Okay.
Representative, yes, sir.
All right. So, I guess my concern is, as I look at the nursing profession, it's wide. I mean, you got ICU nurses, you got primary care nurses, all these, home, kind of in the life nursing. There's all sorts of nursing. And for me, this type of nursing does fall within a healthcare kind of environment. This is independent person. I mean, people trying to maintain their independence, like in a facility, and to say just because I'm a nurse and I'm certified by the broad nursing banner, I don't necessarily think gives the right type of oversight for again, this type of nursing. So what specifically about having the nursing certification gives us an assurance that you fully understand how to operate in this more protected environment?
Yes, ma'am. You're recognized.
Sorry, I'm
You're
learning.
good. No, you're perfect.
Can you ask that question again? Like what you said?
Okay, yeah.
So my question is, you said that part of this bill takes away the healthcare commission oversight over your program. It makes, if you're only dealing with one nurse dealing with whatever number, that, and your answer was, we're certified nurses, basically. There's a state nursing certification. I don't know the exact terminology, and that should be sufficient. I guess my question, my concern is, nursing is a wide field, and just because you're certified as a nurse, what specifically qualifies you to do nursing in people's homes, like this commission governs?
You're recognized,
If the
ma'am.
way I understand the bill, we would be under the Health Facility Commission. And I did try to do that. When within this program, you get a waiver on the certificate of need. And then I went to apply for the licensure. And where the obstacles are is when, you think about the office. Office really isn't a place. An office is where you have an administrative staff. And that would make us have to hire people. So that's why we were trying to make it where we don't have to hire people, so we don't have an administrator. We do, in there, and then also the office, and then just the limiting number of patients just for competitiveness, I guess.
Yes, sir. Any more questions for the speakers? Thank you guys for being here and for traveling up especially. Without objection, we'll go back in session. Chairman, you are recognized.
Okay, thank you, Mr. Chairman. And I just want to, before I forget, we had a bunch of guests here today. If you all care to raise your hand, we have independent nurses, and we also have some patients with us today. We've got a bunch of people here in support of the bill. And I think, correct me if I'm wrong, I think the healthcare facilities people wanted to speak on this too, I believe. Is that correct?
That was the only one we had. Those two are the two that we had today on the list.
Sorry, I
No,
thought
you're good.
I thought she was wanting to. Okay. So with that, Mr. Chairman, you've heard what we're talking about. And this is just simply, we're not trying to do away with healthcare organization. The bill is passed. It was simply an exemption to have for those people that only serve 4 or few patients like that, because it's just hard to set up an office, hire a staff, do everything like that if you just have a couple of patients. So that's what
Thank
it's
you,
for.
Chairman. Any questions for the chairman? Not seeing any. Mr. Clerk, if you don't mind opening the vote, all those in favor of House Bill 2088, press aye. Those opposed, no. All members voted. Any member wish to change their vote? Mr. Clerk, please take the vote.
Mr. Chairman, you have 1 aye, 7 nays, and 0 present not voting.
The nay has it. Bell fails. Thank you, Mr. Chairman.
Sorry.
We're going to move out of order again one more time to House Bill 0398.
Oh, okay.
Yep.
I had another one. You want me to do?
We're going to run to this one. I'm sorry. Get
Gotcha.
this
Okay.
one going.
Gotcha.
House Bill 0398 by Chairman Williams. You got a motion and second. I believe you have an amendment, sir.
I do. Thank you, Chairman and members. Drafting code 014083.
That is correct. Get a motion and second. All in favor say aye.
Aye.
Opposed, no. The ayes have it. You are properly recognized.
Thank you, Chairman and members. This bill, this amendment rewrites the bill. I found a lingering caption, thanks to a couple of colleagues for my district. The former ES director in Cookville Regional Medical Center is Sullivan Smith. Currently in state statute, if our EMS teams come upon, let's say, an automobile accident and Good Samaritans are taking care of a citizen by giving them CPR, according to the current statute, they can't, they have to continue that CPR on that person first, even though they may have no chance of recovering until a doctor calls that and they're able to move to the people that are also seriously hurt on the scene. What this bill does, it mirrors Kentucky statute to allow EMS to be able to currently or effectively triage the scene, care for those that are there who need their help the most. And that's what this bill does, Chairman and members. I'm happy to answer any questions you might have.
Thank you, committee. Any questions? Representative McKenty, you recognize?
Thank you, Mr. Chair. And to the sponsor, thank you for bringing this bill. I actually had a person, I don't know if she was in my district or not, but she brought this exact same scenario that you spoke of. And they know the law. Unfortunately, you know, they're taught the law and they know what they're legally have to do in that situation. And it put her in a bind. So again, thank you for this piece of legislation that will clear that up. They're medical professionals in terms of knowing, you know, what's going on with the person that they're giving life-saving energy to, and there may be a greater good somewhere else. So again, thank you for bringing the bill.
Questions have been called. All those in favor of House Bill 0398, press aye. All those opposed, no. All members voted. Any member wish to change their vote? Not seeing any. Mr. Clerk, please take the vote.
Mr. Chairman, you have 9 ayes and 0 nays.
The ayes have it. House Bill 0398 moves on to Health 4. And this gets us up to item number 35, House Bill 1952 by Chairman Williams.
Thank you, Chairman. I'll second my own bill as a member of the committee.
Motion and second. You're properly, we have an amendment on the bill, I do believe.
I do have one that I'd like to put on the bill that clarifies some language, drafting code 014026.
You got amendment? Motion, second. We are properly, all those in favor say aye. Aye. Opposed? No. The ayes have it. You are properly recognized.
Thank you, Chairman and members. This bill is modernizing the Tennessee Optometry Act for the state of Tennessee. Came to find out why this interests me is this body has been asked earlier this year to expend a little over $1 billion on rural health transformation across our state to try to help improve rural access. What we found out is that we have a problem with access because we don't have access to care providers, healthcare providers in those rural areas. And so this is a bill to attempt to do that. I would consider it as much as a workforce development bill as anything. Currently, in West Tennessee, we have a college of optometry there, where a lot of the Tennessee residents who go there to train to become optometrists will actually choose to practice optometry out of the state of Tennessee because they're able to use the full scope of the practice in which they are trained for, which is mind-boggling. You could grow up in Knoxville and love the Vols, want to come back and practice optometry, but you can't do that to the full extent of your training in Tennessee. And there are 14 other states that allow that training, and a lot of those citizens that were born and raised in Tennessee are going to practice in those other 14 states because they can, quite frankly, use the full scope of the training that they have, that they're learning there in the school. It's interesting, too, because 57 counties in Tennessee currently don't have an ophthalmologist. And so optometry is the last vestige of rural support that folks have as it relates to eye care. And so that's what this bill does. It clearly and narrowly defines what 3 additional scopes that these optometrists are trained for. Quite frankly, when I talk to my optometrist, he's like, I ain't doing it. But his grandson may want to do it, and his grandson would be trained to do it to be the 3rd generation optometrist. The 3 things that it does do are a YAG laser capsulotomy, which clearly clears cloudy membranes around the eye, a selective laser trabescopulosity. Some come son up. I failed Latin. I did fail Latin in college, but it was really important to do that. And a YAG peripheral iterotomy. And so with those things, Chairman, members, I know there are some people here to testify, but I appreciate the members and their support.
Thank you.
Passage, yeah.
Thank you, Chairman. We do have several members that'd like to speak. So without objection, we will go out of session. And I'll call you guys up if you don't mind coming forward. Miss Frances Bynum, Croner Kepperman, David Hall, and Brent Abbey. Those that are here today, if you don't mind coming on up. And we'll do that just as we did previously. If you don't mind having a seat, you'll each get 3 minutes. And we'll start stating your name for the record, and then we will go from there. Any preference? I'll start over here. We'll go with you, sir. Here.
Sounds good. The defense will go first. Thank you, Mr. Chairman, committee members. My name is Dr. Brent Abbey. I am an eye surgeon from Johnson City, Tennessee. I strongly oppose this bill along with my colleagues in defense of patient safety. Supporters of this bill will tell you it is about improving access to care, but the data simply does not support this claim. The Senate heard testimony about a patient who lost vision because their rural optometrist was not allowed to perform laser eye surgery. In my experience, patients with severe pain and profuse vomiting go to the emergency room, not their local eye doctor. I personally take call at a level 1 trauma center where ER physicians within a 150-mile radius can reach me within minutes to start IV treatment and arrange transfer regardless of a patient's ability to pay. My research at East Tennessee State University focuses specifically on access to care for rural patients and patients on TennCare. Nearly 94% of Tennesseans live closer to an ophthalmologist than their nearest Walmart. This bill is not about access to care. It is about lowering the bar for who is allowed to perform surgery on a Tennessean's eye. To put this into perspective, trauma surgeons in my hospital system, physicians who crack open chests in the trauma bay, don't stick needles in the eye because they recognize the level of specialized training required. I want to be clear. I work closely with optometrists, excellent optometrists. They are an essential part of the eye care team, but I personally receive incorrect referrals from optometrists every month for patients who do not need laser treatment. A glaucoma subspecialist in our city estimates that up to 25% of referrals for these lasers are actually misdiagnosed. Without ophthalmology involvement, those patients would receive unnecessary or incorrect laser procedures. When the wrong laser is performed on the wrong patient, the consequences can be immediate and permanent. Supporters claim low complication rates in other states, but those numbers are underreported. Across the country, ophthalmologists are seeing patients referred after complications from these procedures. Someone more cynical than I might note that optometrists in these states are incentivized to underreport their complications. I am concerned they are not recognizing complications when they occur. This bill would allow the Board of Optometry, a non-surgical board, to credential and oversee surgical procedures performed by its own members. This cannot be allowed to happen. The Kentucky Board of Optometry is a prime example of failed oversight. Yes, other states have approved the use of lasers for optometrists, but those states comprise less than 13% of the U.S. population. Let's learn from their mistakes. Our patients deserve the highest standard of care. They deserve surgeons who have completed medical school, surgical residency, and thousands of hours of training managing both the procedure and its complication. Your mother doesn't know the difference between an optometrist and an ophthalmologist, but who are you going to take her to for your laser eye surgery? The thought of a non-surgeon performing surgery on a patient's eye should concern every one of us. I respectfully urge you to reject this bill and prioritize the safety and vision of the constituents you represent. Thank you, Mr. Chairman.
Thank you, Doctor. Appreciate that. Ma'am, you'll be next.
Thank you, Mr. Chairman, members of the committee. I'm Dr. Frances Bynum, a licensed optometric physician in Tennessee, also the owner of a practice in Martin, Tennessee. After graduating optometry school at Southern College of Optometry, I decided to make Tennessee my home because the laws here allowed me to practice what I had been taught in school. A lot's changed and progressed in 30 years. I have continued to learn procedures and invested in new technologies to bring the best care and safety for patients. However, our state laws for optometry need modernization. I would like to tell you about a patient, Mr. Preventable. I have staff privileges at the local rural hospital, so I was called one night to consult on a patient, Mr. Preventable. Mr. Preventable had intense pain due to angle closure glaucoma. Here's a simple way to picture that. Inside your eye, fluid is constantly made and drained, much like a sink. Angle closure is when a stopper is put in the drain. The eye pressure goes sky high. It creates blurred vision, nausea, headaches. The elevated pressure will put pressure on the optic nerve, which will result in vision loss. That is horrible. And this is what was happening to Mr. Preventable. Now, with medications, I was able to temporarily lower his eye pressure, but this was only a temporary fix. What he needed was a laser done, a little small hole that's put in the iris that would relieve this pressure and help better flow. Mr. Preventable failed to follow up with an ophthalmologist 60 miles away due to transportation and cost issues. If I had been able to perform this procedure on Mr. Preventable, I could have prevented vision loss. Unfortunately, Mr. Preventable now is blind in his right eye. One of the laser procedures we are asking to perform is a peripheral iridotomy. So 1 in 3 Tennesseans live in rural areas. Many ODs like me proudly take care of patients in these rural areas. However, access has been limited by our laws. Currently, I send lasers such as the select laser trabeculectomy, the YAG capsulotomy, and peripheral iridotomies across state lines to Murray, Kentucky, to optometrists for these procedures. I would certainly like to keep these patients from traveling across state lines and keep these dollars in our rural community. I trust that you, the Tennessee Assembly, will modernize our state laws so qualified optometrists can continue to provide the best care and safety to the residents of this great state.
Thank you, Doctor. Right at 3 minutes. Sir, you're next.
Dr. David Hall, I'm an associate professor at Southern College of Optometry. Have been an optometric physician for well over 32 years, in private practice in Oklahoma for 22 of those years, where I performed thousands of these procedures successfully.
My name is Dr. Connor Kapperman. I'm from Chattanooga, Tennessee, in private practice. I'm here to represent a perspective, as Representative Williams said, born and raised in Tennessee, very proud Tennessean. But when I graduated Southern College of Optometry, I wanted to work to my full potential. So I left the state. I'm back now due to family circumstances, but I performed well over 100 of these procedures safely out of state. And now that I'm home, I feel like I've taken a step back in my career. My patients ask me, why can't I perform them? And I said I can, but but because of legal reasons, I'm not allowed to.
Would you like to add anything?
Sure, if it pleases the chair.
Yes, sir, you're good.
Sure. All 23 of our accredited optometry schools in the United States teach these procedures in this bill, many since the early 1990s. These are established components of doctoral level training. Programs are accredited by the Accreditation Council on Optometric Education, which enforces rigorous national standards to ensure competency and patient safety. Healthcare professions evolve as education and technology advances. Optometry is no different. Updating Tennessee's statutes will align the law with current training, improve patient access, and support a modern healthcare workforce. Thank you.
Thank you, sir. Members of the committee, any questions for the speakers? Representative McKenzie, you're recognized.
Thank you, Mr. Chair. To your knowledge, I know you're not lawyers or you're not, but to your knowledge, does this bill limit you to these 3 procedures that you're asking permission to have?
You're recognized, sir.
Thank you, Mr. Chairman. Excellent question. That's why the amendment was added, just to add clarification that these are the 3 laser procedures that we would be able to perform.
Thank you.
Yes, sir. You're recognized.
The bill does state that those are the only 3 ways, the only way that they can perform those 3 procedures is by laser, as if you could do it in a different way, but it does not limit this bill to only those procedures. It includes fillers around the eye that could cause vision loss and strokes. It allows an optometrist to stick a needle into the eye, which is personally terrifying. It is not something that a non-surgeon is trained to do. It's something I've done many times, and every time there's a certain level of discomfort because, as the patient was mentioned, Mr. Preventable, I have never performed a YAG PI in the past 5 years without first sticking a needle in the patient's eye, because the cornea is usually so foggy and the eye is so hard that you have to do that to be able to see through the cornea and perform an effective PI. That's probably why some of our research is showing many lasers are repeated by optometrists much more than our ophthalmology colleagues in these other states.
You're recognized.
Thank you, and thank you all for coming up here and testifying. And I want to thank everybody that's worked on this piece of legislation. And I think most people know that I've probably asked a ton of questions on this, and I'm not sure that I am there on this, but I do have a question. This really kind of goes back to the Mr. Preventable type scenario, and that's something for me it's kind of personal. I've had laser eye surgery before, and I had an open globe injury. And so those are timely, it's a timely manner in which you have to have, in fact, actually delayed me running for office, making sure I had my vision. So that was back in 2013. But one of the concerns that I have with this and bringing this up, obviously having something preventable, and that's when you have a complication from one of these procedures, and then having timely follow-up to those complications. And some of those, my understanding is, and maybe you can, Dr. Abbey can explain this, the timely manner in which something could be taken care of from increased pressure after one of these surgeries that maybe they can do that you may not be able to do. The bill as it's currently written, I don't know. I know I've been told that there's referral bases that you have, but I don't see anything in there that has that timely manner to which they can get them to. And anyway, if you could address that, because that's one of my main concerns is a post-op complication and not getting to somebody that can actually do that.
You recognize, Doctor.
Yeah, some feedback we've gotten from the Hill is we're tired of hearing about anecdotes and potential, scare tactics and stories. We want to hear about real patients. Each of you has received letters from ophthalmology groups in Oklahoma and Kentucky where we are seeing some of these procedures. Keep in mind, 87% of Americans still live in states that only allow an eye surgeon to perform these surgeries. And we're talking about modernizing. The question asked by council member. The YAG PI. Here's what concerns me. When patients are referred to the glaucoma subspecialist I mentioned that lives in our city, Representative Hicks, and they're referred for an SLT, but there's neovascular glaucoma, or they're referred for a PI, and our blood vessels growing on the iris. Performing the wrong laser on the wrong patient can be devastating, and there's no amount of follow-up is going to get that vision back.
I guess if you could clarify more, because I think you brought up cracking a chest, and that's one of my concerns is like from a heart cath. If you're doing a heart cath on somebody, you have to be within 30 miles or 30 minutes to have somebody in case something happens with that procedure and a complication. And just educate me on this.
Yeah. So you have a patient who you perform a PI and there's iris bleeding. That would be the only circumstance where I would use a paracentesis, sticking a needle in the eye after one of these lasers has been performed. If the bleeding does not stop and the pressure does not go down with medical therapy, that patient needs to be taken to surgery, where I have privileges at a surgery center, at a hospital, and at the level 1 trauma center. And the immediate follow-up care is surgical. I guess my question would be, we act like there's a rural issue. We're having trouble sending patients to their closest ophthalmologist. Every optometrist here has an ophthalmologist they refer their patients to for cataract surgery. Those should be physicians who are willing and ready to take care of your emergencies as well. And I have never found that to be lacking in a specialist.
Representative Gant, you're recognized.
Thank you, Mr. Chairman. Let me go back to the post-op that you were talking about. If a optometrist does this procedure that we're voting on today and there is serious complications, I've heard that from Dr. Terry, I think what I heard is they have to come to you, an ophthalmologist, to be treated. Is that correct if there's post-op serious complications?
You recognize that.
As the law stands now, surgery is only done by surgeons who are able to fix their own complications if something were to happen. As the law is proposed, I assume that we need to get them to a qualified surgeon as soon as possible.
Okay. What is the cost of most of these procedures? Is it a money-making mechanism? Is it convenience of rural Tennessee? I'm trying to get to the heart of the issue here.
As an academic physician, I don't always pay close attention to the CPT codes. I do know the SLT is not considered a very highly reimbursing CPT code, as is the YAG PI. The YAG capsulotomy, I imagine when you're billing Medicare, you're probably making about $300 for the practice, somewhere close to that. For the SLT, often we will perform that procedure. It's the one that we'll do bilaterally. When you do a bilateral procedure, you get paid half for the second eye, but most ophthalmologists do that because we don't want patients driving all across the state of Tennessee when we can help it. We typically only do one eye at a time in more risky procedures like the YAG, PI, or capsulotomy.
Okay, Mr. Chairman, if I can continue.
Yes, sir, you're recognized.
And the same question goes to the optometrist side. If there are complications to a laser surgery or one of these type surgeries, and is that going to be an issue where y'all could not address that concern? And would they have to go to an ophthalmologist to be addressed?
You recognize, sir.
Thank you for the question. I'm glad that you're going to ask us to respond to that, because there are situations, we've been treating post-op care for decades now for cataract surgery, glaucoma surgeries, retinal surgeries, lid surgeries, cataract surgeries, as well as in Tennessee, laser surgeries that have been performed by ophthalmology. Anytime that we see something that is outside of our scope, then yes, of course, we're going to refer that out, just like any other general ophthalmologist would. If they had a situation where they could not medically decrease the pressure, either through a PI or a paracentesis, that patient would have to go to a higher level of care. That is not unlike how general ophthalmologists would handle these types of cases as well. And we've been treating these complications. We've been seeing these complications, treating these complications for several decades now. And so our referral pattern would not change if we were doing these procedures. One, there are very few severe complications that can arise from these, although they do happen. Most of the time, because we've seen these for so many years, we can address those ourselves. Very rarely are we going to need to send them on to something much more invasive than that. These are very rare cases that have been brought up today. They do happen, but yes, we would of course be sending those out to the right specialist. It probably would not be a general ophthalmologist. It would be a specialist of some sort. And yes, of course, we do that all the time still in our practices.
So what happens in the event that the proximity is many miles away and there's a complication here? What does the patient do?
Well, the first thing that we have to do, thank you for the, yes. The first thing that we have to do is we have to find somebody that's willing to take the patient, which there are hundreds of stories where unfortunately doctors aren't on call and they're not nearby, nor are they taking patients at that particular time. And so that problem is always present, especially not only in a rural part of Tennessee or a state, but even in urban areas. It can be very difficult sometimes to find a specialist that's available. And so that is something that's always difficult to do, but hopefully we all have specialists that we're close to, that are on our speed dials, that we have good relationship with. And we know the ones that will take that patient immediately whenever they get a text from us, and we know the ones that may not be available.
Yeah, Representative, you're recognized.
Thank you, Mr. Chairman. In the rural areas, and I represent a very rural area, and in the offices that we're looking to expand this in, what is the cost of these laser machines? Are they going to be able to afford these machines?
East Tennessee State just purchased one. If I feel more confident about that than the reimbursement for a YAG. They're about $80,000. And there's research in medical journals that shows that when these privileges are extended to optometrists, again, for less than 13% of Americans, that it does not improve access to care. One study published in the Journal of the American Medical Association showed it actually increased drives for some patients because referral patterns changed.
Representative.
So what you're saying is there is an affordability issue there.
I think so.
Would you like? Sure.
Yes, sir.
I just, SEO just purchased a brand new laser of this nature this past week, and we spent $50,000 on it. That's a brand new unit. And in my own private practice, whenever I was performing these lasers in Oklahoma, you can get a very, very high quality laser, combination laser for less than $25,000. That's still under excellent warranty, and I never had any trouble with those lasers. So this is not, number one, not every optometrist is going to choose to do these procedures. Yeah. Number two, the folks that are going to do these procedures know that there is some outlay of capital, but to take the very best care of our patients and to practice at the highest level that we're trained to, then that's a very small cost to these practitioners to take good care of the people that they go to church with, that they see at Kroger, that they meet on the neighborhood, that they are seeing on a regular basis for generations.
Representative Gant, one last one.
Thank you, Mr. Chairman, for indulging me here. I promise this will be quick. The other 16 states, what major complications have we seen in those states with this if we pass it? And they obviously have, they have passed it.
Either one of y'all want to go first, real fast?
Thank you, Mr. Chairman. Thank you for the question. There is a study done just 3 or 4 years ago of 145,000 optometry performed laser procedures. And in that case, the percentage of complications following it was almost exactly the same as those performed by ophthalmology, less than 0.001%.
And then, Doctor, you're recognized. Do you have that report as well, or no?
I've read the report. The concern is that these are being underreported. So typically what is happening in talking with colleagues, we're going a little anecdotal here in these states. Those patients are sent from the optometrist to their referring ophthalmologist. And those patients are patched up and fixed up and sometimes have lasting vision damage. And there might be an incentive not to report. At the same time, this is back to our discussion. Who do you report to? The Board of Medicine. Optometrists aren't under that. The Board of Optometry. I don't know that they're able to regulate a surgical board. And that's our big concern. In Kentucky, 21 optometrists were given the ability to do these lasers while being opted out of testing. There's a current malpractice case pending in Kentucky. I just don't think it's worth doing here in Tennessee.
Without any additional question, we'll go back in session. Thank you guys for enlightening us on. Chairman Williams, you're recognized.
Well, just anecdotally, I think they communicated less than 1,000 to 1% or complications associated with them doing this. I think obviously they're able to do it in other states. And you heard from a physician, an optometrist who's literally had to come home, and he's excited about being able to do what he did in another state. This is, I think, really important. I will say additionally that the amendment did clarify that optometrists will not be performing intravenous injections. And that was at the request of the retina specialist that we communicated with. This is not something that we haven't taken seriously as it relates to make sure that we're narrowly drafting what the bill does. That's what this bill does. It's different than the Senate because it's very more specific, and the guardrails are in place to protect patients, which is the most important thing. Thank you. And I move passage. I renew my motion.
Any more questions for the sponsor? Not seeing any. All question has been called. Mr. Clerk, please open the vote. All those in favor of House Bill 1952, press aye. All those opposed, no. Have all members voted? Any members wish to change their vote? Not seeing any. Mr. Clerk, please take the vote.
Mr. Chairman, you have 6 ayes, 3 nays, and 0 present not voting.
The ayes have it. House Bill 1952 moves on to health full. All remaining bills will be rolled to next calendar. And without objection, we are adjourned.